Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Lake Superior Quality Innovation Network's Detailed Changes to Meaningful Use 1 and 2 through 2017 conference call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Candy Hansen. Ms. Hansen, the floor is yours.
Thank you so much. Before I introduce Dr. Kleberg, I just wanted to let everyone know that the presentation slides from last week's webinar, as well as this week's webinar, as well as the evaluation links will be sent for both sessions, will be sent out by tomorrow via email to everyone who has registered for these webinars. So our speaker today is Dr. Paul Kleberg. Dr. Kleberg has played key roles in EHR implementations in integrated delivery systems and is passionate about leveraging health information technology to improve care. Dr. Kleberg is the Chief Medical Informatics Officer for Stratus Health in Minnesota and Clinical Director for the Regional Extension Assistance Center for HIT for Health Information Technology for Minnesota and North Dakota. Dr. Kleberg also serves as our National Coordinating Center Team's Health Information Technology Expert. Thank you for joining us today, Dr. Kleberg.
Thank you, Candy, and hello, everyone. I think it's still morning for most everybody on the call. We apologize for the delay. We had a little bit of technical difficulties, but we'll still have plenty of time to cover the material and also potentially ask some of the questions that come in. We will have time for open mic questions at the end, but what I would like to emphasize is that you're welcome to enter these questions into the chat, and when you do, if you can send them just to the presenters so that you don't feel like you're sharing information with everybody out there, because sometimes we found that people are a little bit shy about asking questions because they think they might be done. So when you're going to send your chat question, if you direct it to the presenters, we will be the only ones to see it, but yet we will be able to answer them to everyone. So without further ado, I think I'll get started. Let's see here. If I can get the mouse to move. Here we go. So we're going to provide an overview of the changes in Stage 1 and Stage 2 through 2017. We're not going to talk at all about Stage 3. And this will enable you what you have to do now and allow sometimes for questions and potentially discussion at the end. I can't answer all questions definitively. We will keep track of everything that is asked in the chat, and if I do not have the answers, we will get back to you with answers at a later time. The Lake Superior Quality Improvement Network is a combination of 3 organizations, all quality improvement organizations, MPRO in Michigan, Stratus Health in Minnesota, Medistar in Wisconsin. Again, our focus is to help improve the quality of care for Medicare consumers. We share best practices, and we also wish to maximize efficiencies. And all of us are focused on the leveraging of health information technology to improve care, because you can't really know what you're doing when it's only on paper. You really need to be able to analyze the technologies. So as you know, the final rule was released on October 16th, and it's actually a final rule with comments, which had a number of people scratching their heads. What were the comments about? The comment period will close on December 15th, and what they're basically looking at the comments is because this rule closed, or actually this rule came out after the MACRA legislation was signed by President Obama, which actually changes things about meaningful use and everything starting in 2019. So this rule actually allows you the opportunity to make some comments which may be used in further rulemaking. Unlike previous NPRMs, this rule does not have specific questions in it, but there is just a general question somewhere in the beginning. If you have the PDF version of the document, there's a question at the beginning that just asks for general comments about this rule. So that comment period is open until December 15th, and they will be looking at it. I'm not sure what sort of response will come as a result, because there's no expected final rule to follow. All right, you're familiar with this timeline. This was from the proposed rule, but I plugged it in here just for the sake of so you can see it. We have a 90-day reporting period for all in 2015 and 2017. So the 90-day reporting period in 2015 is new, and 2017 will be for those who are moving to MU3. So you have 90 days if you're choosing to do MU3 in 2017. Providers will be scheduled to do meaningful use 1. Now, technically, everybody is supposedly doing a stage 2, but you're doing a modified stage 2 if you were scheduled to be doing stage 1. That's where there was some confusion last week. I thought there was no stage 1. There isn't a stage 1. It's a modified stage 2, but you only get to do the modified stage 2 if you were to be scheduled in stage 1 that year. So if you look at the 2017 column in the center of your screen, you see stage 2, or you see stage 1 in 2016, and that's actually the modified stage 2. And we'll talk about which of these objectives actually have modifications. But in 2017, everyone, regardless of stage, is going to be needing to do stage 2. I see the nephrologist and the endocrinologist question. We'll get to that when we get to that later on in the registry component. So we're moving now to a reporting period where there's a calendar year for all. And actually, because of this transition, hospitals have 15 months that they can use for the 90-day reporting period for the 2014 reporting period. I'm sorry, the 2015 reporting period. We mentioned 90 days for 2015, and then we mentioned the fact that it's any 90 days for first-time attesters in 2016 and 2017, kind of error. And those attempting to meaningful use in 2017. I'm sorry. So it's 90 days for the first-time attesters in 2016, and in 2017, those attempting meaningful use 3. It's full year for anybody beyond their first year in 2016 and 2017.
Could I ask a question? So a calendar year for all for the hospital. Is the reporting performance period 15 months, or is it 12 or 15 months? Is there a choice?
They can choose any 90 days in that 15-month period.
Okay, thank you.
So attestation, no changes to the method. All Medicare, no 2015 Medicare attestations before January 2016. We know that they're doing that because they need to modify the attestation. The deadlines for everyone is going to be the last day in February. And if you're a Medicaid provider and you fall below the 30% threshold or the 20% threshold, you will be able to attest to meaningful use without switching to Medicare, so you can still stay in the Medicaid program and not be penalized under the Medicare program. I think that was in the proposed rule. That's unchanged. Penalties and exceptions. These really are unchanged except for a couple of things. Anyone attesting for the first time before February 29th will not be penalized in either 2016 or 2017. So, they were saying in the proposed rule that it was going to be a full reporting year for everybody starting in 2017, but because of that, you'll see in the second item, October 1, you will not be penalized in 2017 and 2018 if you attest before October 1 of 2016, and if you're a first-time attester in 2017, you will not be penalized in 2018, and we're not sure what's going to be happening in 2019 because of the rule changes. So, I've got a couple of questions here. I'll see if I can answer some of these. So after that question that was presented, 2015 also goes for those in either stage 1 or stage 2. It's a 90-day reporting period for anyone in stage 1 or stage 2 for the 2015 reporting year. So all those who are unable to attest in 2015 due to the final rule delay, there is an exception application that will be available early in 2016. And the next slide actually reports out that FAQ that came. So apparently, if you attested in 2014 and were unable to configure your EHR, do the work that you needed to do because you were unsure about how the final rule was going to come out, because it came out so late, you were unable to attest for the 2015 year,
you will have the ability to ask for this exclusion for the 2017 penalty year. So if you were unable to attest for 2015, you would not get a penalty in 2017 if they accepted that hardship exception that you've applied for. Now, for first-time attesters, they would still wind up being penalized in 2016 if I read these rules correctly, because you can't, the application period for the reporting period for 2015 is already closed. So state flexibility is unchanged. Paper-based documents are pretty much eliminated on both stage 1 and stage 2, except for patient education materials. You're able to count any paper-based documents that you give to your patients, and we'll go over these specific elements as we go through here. So the proposed program goals and objectives for stage 1 and stage 2 are these. I mentioned last week that the order of them and the nomenclature of them change between stage 2 and stage 3. So you know how you always ask a question about objective number 4. Now it's going to be so dependent upon what year you're talking about. If you do ask questions, it's better to state the specific objective that you're talking about, because they're changing the nomenclature throughout these two portions of the final rule. So I talked about this one last week. I'm going to skip over this because I duplicated it later on. Apparently forgot to eliminate the slide. But from here we're going to go into some of the very specifics of all these rules. So the first one is the security risk analysis. It was a core in stage 1. It was a core in stage 2, and it changed only because they included the encryption security of data stored within the EHR. Now with the final rule, it is really unchanged, except they also imply it's not just if it's stored in certified electronic health technology, but they say in any manner or form in which it's stored. So just be aware that, again, this is something to which you attest that you've done the security risk analysis to make sure the data is secure. You need to do it every year. You can do it, if it's your first time attesting, you can do it before the measurement period and count it for the attestation. But beyond your first year, it has to be sometime during the year, not necessarily the attestation period, but sometime during that year. And you'll see the link here goes directly to the HTML version of the Federal Register for the particular final rule. So when you do get these slides, you can actually click on the links, and they'll bring you to all the detail within the rule about these particular objectives. I'm going to go through all these, and I'm going to ask my support folks here to help me go through the chat so that I can answer the questions, because I think I'm going to the questions are involved, and my concern is that if I spend time reading the questions, I won't be as efficient as I'd like to be, because it's a lot to cover. So, clinical decision support. Really, that's unchanged for stage 1 and stage 2, except for stage 1 in 2016 and 2017, you're going to have to do 5 rules. So nothing else about it has changed from what we were doing for stage 2. Again, what's happening for those folks who would have been at stage 1 in any of those years, they're going to be doing the stage 2 requirement, which is basically 5 CDS interventions. There are no exclusions, and it's just a yes or no to which you attest. Drug and drug allergy interaction checks. Again, that's also unchanged from the proposed rule, and unchanged for stage 1 and stage 2, because it has to be on throughout the entire measurement period. There is an exclusion if you write that less than 100 medication orders if in stage 2. Now, even though you have a 90-day reporting period, it's still 100 medication orders. In past, they actually reduced that number to 25. Apparently, they're not doing that anymore. So if you're reporting for a whole year, if you write less than 100 medication orders as an eligible professional, Or if you're just reporting for 90 days, which everyone will be in 2015, if you write less than 100 medication orders during that time period for eligible medications, you would not have to have the drug interaction check turned on. Computerized provider order entry. This is actually 3 measures that I combined into one here. For those in stage 1, it really was and still is 30% of patients have at least one medication ordered by a CPOE, or 30% of all orders are ordered by a CPOE, and that still holds true for those in stage 1 in 2015. But in 2016, it will then move to the stage 2 requirement for everyone. And the stage 2 requirement is really unchanged in the final rule, but for those, and that again is 60% of all medication orders, 30% of all laboratory orders, and 30% of all radiology orders must be entered using computerized provider order entry. There are exclusions for professionals. If you write less than 100 medication orders, or if you write less than 100 radiology orders, or less than 100 laboratory orders, you may exclude that particular measure from your reporting. So again, if you don't order any radiology, you would not need to report on that particular element. Now, there are some additional exclusions for those people who would have been at stage 1 in 2016. And this is called the modified stage 2. You may exclude both lab and radiology orders in 2016. So for stage 1, all you'll need to do is the regular stage 1 in 2015, but in stage 2, but in 2016, if you were to still be at stage 1, you would have to do 60% of all of your medication orders, and that would be it. The other 2 you would be able to exclude. E-prescribing for stage 1 has been 40% of all permissible scripts. It was increased to 50% of all permissible scripts for stage 2. For both of those, there are exclusions for less than 100 scripts or permissible scripts, and there are also exclusions for if there were no pharmacies that accepted these within 10 miles. For stage 1, it's unchanged for 2015 only, but starting in 2016, they'll need to do the stage 2 one, which is 50% of permissible scripts. So for stage 2, those folks in the final rule, it's unchanged, but for stage 1, you'll need to do the stage 2 equivalent. Okay, some good questions here, and I'm going to do my best to move through them quickly towards the end here. Discharge e-prescriptions. Okay, there weren't any for the hospitals in stage 1. And by the way, all of these are for both professionals and hospitals unless they're labeled at the top eligible hospital, EH or EP. So this is just for hospitals. So this is for e-prescribing for hospitals that are discharging patients. Stage 2 measure was 10% of all hospital patients had to have their permissible scripts needs to be ordered by a CPOE, or actually by e-prescribing, I should say. There was the exclusion of no internal pharmacy and not one located within 10 miles of any pharmacy that accepts these e-prescriptions. In the final rule, they had suggested in the proposed rule that it would include refills. They eliminated the idea of refills in the final rule. So refills are no longer included in this measure. You don't need to keep them in your denominator. And it's also not required in 2015 or 2016 because it was a menu item in 2016. And because it was a menu item, a lot of hospitals hadn't decided to implement it. So there was no way they could require it in 2015, but they had planned on requiring it in 2016. Well, since the rule just came out a couple of weeks ago, how could a hospital possibly implement discharge e-prescribing and have it in place and have it have to purchase it, implement it, get their workflows and do all that stuff by January 1. So consequently, they've given a buy for all the hospitals at stage 2 to not have to do this in 2016, but it will be required for everyone in 2017, and it's basically unchanged from the rule as it was described for stage 2, but it's no longer a menu item, it's a requirement. So to restate that, For everyone, all hospitals, discharge e-prescribing is a requirement starting in 2017. It is not required in 2015 or 2016, and it just no longer includes the fact that you would have to e-prescribe refills. Drug formulary check. Now, that was one that was implemented as a separate item within the stage 1 for everybody. Implement drug formulary checks. It was a menu item. When we went into stage 2, for professionals, it was incorporated into the e-prescribing core item, so it's just a part of that item. And for hospitals, it was incorporated into the e-prescribing menu item for hospitals. So in 2015, again, EPs may claim this as an exclusion so that they don't have to report this particular item. But in 2016 and 2017, it's going to be a part of the e-prescribing item for both hospitals and eligible professionals. Again, hospitals don't have to do the e-prescribing in 2016 and 17, but if they do, they would be reporting the drug interaction on e-prescribing for discharge meds.
And the exclusions go away for stage 2 and or for 2016 and 2017?
The exclusions would remain the same for EPs. That's interesting. I didn't include that in the column. If the EP writes less than 100 medication orders during the EHR reporting period, that would be true going forward. That one is still there, but there are no exclusions for hospitals.
Okay.
Thank you. I want to correct that on the slide, so please make note of that. Health information exchange. We had a question on this one next week that I'm going to try and answer with this too. Stage 1, 50% of referrals and transitions of care needed to have some summary of care that was sent to the receiving provider. So every time you sent a referral, there needed to be a document that was sent. It didn't matter what the format needed to be, it just needed to be sent. Now for stage 2, there are 3 specific measures for this particular item. 50% had to be sent, 10% had to be sent electronically, or one or more sent electronically to a different provider with a different EMR, or to a CMS-designated test EHR, which became, I think they began to change that second one as time went on. The exclusions, in stage 1, if you don't refer or do any transitions, but they changed that to less than 100 transitions during the EHR reporting period for eligible professionals, but hospitals have no exclusions on this one. But what happens here that's rather interesting is that because you're no longer required to measure paper documents, and for stage 1, paper documents counted, and there was no requirement to send these documents electronically, in stage 1, you can actually claim an exclusion in 2015, and because you didn't have to send them electronically. However, starting in 2016 and 2017, you will be required to send them electronically, and so you will be required to do that stage 2 requirement for 2016 and 2017, and essentially that stage 2 requirement is now, the way it is on the right-hand column, the summary of care is created with certified EHR technology, and greater than 10% of them are electronically exchanged. They're not worried about the different provider with a different EMR, and they're not counting the paper documents anymore. Denominators and exclusions are unchanged. So with this particular measure, and I also want to point this one out, this particular measure, there is the exclusion that you can exclude other providers if they have access to the electronic health record. And this, I think, has inhibited some of the exchange that we've seen out there. Because, for example, if I work at a large system and I provide the nursing home with few access to my EHR, they wind up being excluded from my denominator. That does not change with this final rule for stage 2, but that does change for the final rule for stage 3. Stage 3, view-only access does not count as having access to the EHR. So it will count through 2017, but you will need to figure out ways that you'll be able to allow people to be able to send this information to people when you're making a referral. Now, one of the questions that came in last week that I was unable to answer is that they're having a problem with direct addresses, and if the external provider isn't listed in our directory, and we're unable to send the CCDA to them, will this count against the EP? And the answer actually is yes. Well, we'll count against them in that you have to send 10% of them electronically. So 90% don't need to be sent electronically, so that professional would be, or that person to whom you're referring would be part of the 90% that you don't send electronically. So that's why the bar is relatively low. But we do encourage you to try and find some way that you can send it in such a fashion that it uses the certified EHR technology. There was also a question for the ENT specialist to only receive referrals. Would the transition of care referral measure of 10% electronically be reportable for them, or would they be excluded? You know, I cannot answer that one specifically right now. I've seen discussion on that. I think technically it's not a referral back, but it may be considered a referral back. I mean, best practice would be to send the information back to the provider, and if you can send it back electronically, that would be great. So I would heartily recommend that that be done, because that is best practice. That is what we're trying to accomplish with what we're doing here. But whether or not it is a requirement, I cannot say for sure, and we'll have to look that one up and in order to be able to answer that. I'm sorry I did not have the time to do that before this particular session today.
Paul, one of the questions that just came up is, can you repeat the bit about the difference between stage 2 and 3 denominators? Could you repeat that one more time?
In which measures?
Could the person who wrote that question respond to that, please?
The stage 2 and 3 denominator for HIE, yes. For the stage 2 denominator right now, you do not count other providers who have access to your EHR. So for example, a hospital who's referring a patient to a nursing home, if that hospital provides view access to someone in the nursing home of that EHR, technically they would not need to count them in the denominator. There's that specific language in the first stage 2 rule, and it's unchanged in the final rule for stage 2. But in the stage 3 final rule, view-only access does not eliminate the individual for the denominator. So just because you give somebody in the nursing home the ability to have view access to the EHR does not preclude you from having to send a summary of care document to that nursing home for stage 3. So patient-specific education, again, that was a menu item in stage 1 for 10% of all unique patients. It became a core item for stage 2. For those who would have been for those in stage 1, they may claim an exclusion on the element. Now, what's interesting here, and we don't know the answer to yet, and I'm not sure they figured out an answer to this one, is that you don't have to prove the fact that you're planning on making this element a menu item in order to be able to claim an exclusion. It states it very specifically in the final rule. We're not asking you to be able to attest or demonstrate the fact that you had planned on making this a menu item. So for those in stage 1 who want to claim an exclusion, you don't have to document anything in particular. What I don't know is that if you claim absolutely every exclusion, you would not have been attesting to the number of menu items that you would have had to attest to if you were doing stage 1 in the formal method, because some of them have been eliminated and you would still have had to have done 5 menu items. So you could technically say that you were going to not do all of the ones for which you could get a stage 1 exclusion. CMS has not addressed that. I don't know what's going to happen around that. So just be aware, you probably will need to do some of the stage 1 or stage 2 elements for which you have an exclusion, so that you're not caught in any audit saying, well, you could not have excluded that many. And there's some rather easy ones that you could select that I don't think is going to cause any undue hardship. So again, for the core for stage 2 is 10% of all unique patients are provided patient-specific educational resources. It's really unchanged. Paper still counts. and everyone's going to need to start doing that in 2016 and 2017. And again, for those in stage 1, they may claim an exclusion. Medication reconciliation. So, for stage 1, 50% of transition of care relevant encounters. For stage, that went from a menu item to a core item for stage 2. Again, for stage 1 in 2015, because it was because it was a menu item, you may exclude it, and you don't need to prove the fact that you weren't planning on doing it. Interestingly, it's not one that's particularly challenging, but again, you may choose to exclude that if you wish. But starting in 2016 and 2017, everyone's going to need to do it. And again, stage 2, everyone will need to do it. Needed to do it last year and this year because it's a core item. But it's essentially unchanged. And the exclusions, no transition of care referrals, and none. And again, that also applies to those providers who, whenever you're receiving someone back from another location, you need to do that medication reconciliation. I will be talking about C2M. I can answer that one quickly. Online access to health information. There are a couple of measures here, so this is the first measure. 50% of patients, and this is in stage 1, 50% of patients are provided timely online access to their health information within 4 business days of it being available. It became a core in stage 1. It remained a core in stage 2, and it really is unchanged in the final rule between stage 1 and stage 2 because everyone was doing it. The only exclusion, and this one I didn't really understand until because anytime you see a patient, you're going to have information in it, such as the patient name, the provider's name, contact information. But there are certain exams for the professional which may not be in the EHR, like DOT exams or some other exams that are pretty much just on paper. So those ones wouldn't need to be included in your denominators. But pretty much all your patients are going to be included in your denominator, and greater than 50% of them are provided timely online access. It doesn't mean that they've accessed it. It just means that the information is available there within 4 business days for greater than 50% of your patients. So the second one, which was not part of stage 1, what was part of stage 2 core, was 5% of your patients view, download, or transmit their health information. And there were exclusions for that one. Again, there was a unique patients that were counted. And again, it's the same eligible professional exclusion, but there's also the exclusion for those who greater than 50% of their encounters were in a county where less than 50% of the housing units basically had slow internet, and that was 3 megabits per second, the way it was the way it was designed previously. Now, the new stage 1, starting for 2015, is the stage 2 requirement. You may claim an exclusion for that, and you don't have to worry about that one because it was never even a part. It wasn't even a menu item for stage 1. So you have an exclusion period. For stage 2, it's unexchanged except for 2 things. They made it easier. In 2015 and 2016, it's 1 patient. So you have to have 1 patient that to view, download, and transmit their information. And in 2017, they've made it 5% of the patients that need to have done something like that. And they've also upped the ante on the broadband speed. They made it 4 megabits per second from 3. Woohoo! Anyway, that's that particular rule. So everyone is going to need to be doing that stage 2 requirement starting in 2016 of at least 1 patient doing it, and 5% in 2017. But for those who would have been in stage 1, they can claim the exclusion. So, secure electronic messaging. Again, no requirements in stage 1. Stage 2, again, with 5% of unique patients or their representatives were sent a message to the provider. So that was from the patient to the provider, and there was that same exclusion of no office visits and broadband speed in your neighborhood. This one has changed for the better too, interestingly, is that everyone is going to need to do the stage 2 requirement. But, again, for those people in stage 1, you have an exclusion automatically because it wasn't a requirement for you if you were to do stage 1 in 2015. But they've changed the rule to the fact that it's the provider sending the message. Now, that's way different than trying to get a message from a patient. This is actually the provider sending the message. So, in 2015 and 2016, it's one patient. In 2017, it's 5% of patients. So that is a significant benefit of really now creating more interaction between providers and patients online. Again, the broadband is now up to 4 megabits per second, and you need no office visits to account for that exclusion. So public health and clinical data registries. These are the new. There are 3 stages you can be in order to be able to claim the fact that you're reporting or involved in doing this. So the proposed objective is active engagement with a public health agency or clinical data registry to submit electronic data. Now, the 3 stages are active engagement, and this is how it's defined. The active engagement is you've completed the registration to submit data. So you've worked with your public health agency or you've worked with the clinical data registry and you've applied to submit data. And you're still within the 60 days, you do it within the first 60 days of your reporting period. And if you've yet to receive an invitation to test and validate, you're good. But as soon as you receive an invitation to test and validate, you move to the next level. So here, you must respond to requests to test and validate within the 30 days. So you've got 30 days to respond to that invitation. And then the last one is production, which is active submission of data. So there is this testing and validation period. So if you responded within 30 days and you're in the process of testing and validation, you're good. And then finally, the last stage is production. Again, you can exclude any particular one of these elements, and we'll be talking about which ones they are shortly. But you can exclude them if the agencies are not capable at the start of your particular reporting period. So let's go through what some of these things are. Oh, before I do that, you can choose multiples of some of these. So the first column is for eligible professionals. And for stage 1 in 2015, you choose just one of these elements. For stage 2 and in stage 1 beyond 2016, you would choose 2 of those elements. You can report immunization registry once. You can report syndromic surveillance once. But you could also use 2 different specialized registries for your reporting. So you could say, satisfy this particular element with 2 specific specialized registries as a professional. Now, with hospitals, it's very similar. Stage 1, they have to choose 2, and there were already 2 required for them, actually. We'll talk about that. But in 2016 and on, and everybody in stage 2, you would need to choose 3 of those items. And 3 of them in that particular instance could all be specialized registry reporting. So let's go through each of these. The submit to immunization registries, I think we're all familiar with this one. First, it was a menu item in stage 1. It became a core item in stage 2 or a successful ongoing submission. And the final one for stage 2 is active engagement with the public health agency to submit immunization data. You know, there was some concern that it was supposed to be bidirectional with predictability about what the patient might need. That was eliminated because you can't do that with 2014 certified EHR technology. So basically it's a core 2 measure, and it's the active engagement, which is actually, if you're actively engaged by one of those 3 previous definitions, you can report that this one is one of the ones that you're doing. And the exclusions are really pretty much unchanged. Public health clinical data registry, the syndromic surveillance. So that was the menu item for stage 1. For stage 2, it was a menu item for professionals. It became a core item for hospitals. And now as a final measure, it's again, it's active engagement and it's pretty much unchanged. Now, interestingly, since this was a core item for eligible hospitals, it's one of the ones that you were planning on doing if you could anyway. So that is a benefit to the hospitals in having to choose two. Again, your exclusions for professionals, no category of providers who collect this data. For hospitals, no emergency or urgent care, or there's no agency with the capacity to receive these at the start of your measurement period. So again, if you're unable to do these, you have the exclusion, you can take an exclusion. But again, unless you have exclusions for all of them, you still need to do at least one as a professional in stage 1, 2 as a hospital in stage 1, or 2 as an eligible professional in stage 2, or 3 as an eligible hospital in stage 2. Specialized registries. Again, we can do this one more than once. This one actually is very general, and there was a question on this that I saw in the chat. It's intended to be very general. This includes what was the cancer registry. It can include public health registries. It can include private registries, individual registries. They're being very ambiguous about this one in order to allow for the greatest flexibility. So again, it was successful ongoing submission, but right now it's active engagement. So if you found a registry that you can begin to work with, you're actively engaged according to our previous definition to submit relevant data to a registry. Your exclusions are unchanged if you do not diagnose or treat any relevant diseases for which there are registries that might be capable to receive it. And if there are no registries capable to receive what you can do, then again you can exclude this particular item. So that would allow you to have an exclusion on this. And for hospitals,
could we just, there was a question about, could you please explain active engagement again?
All right, I'll go back, hang on, I'll go back to that slide. Oops. You gotta go back to it, sorry. Active engagement. All right, completed registration to submit data. So if you've within the first 60 days of your reporting period, you've applied with either one of these registries or immunizations or syndromic surveillance to begin to report this stuff. And again, obviously the agency has to be capable of receiving it. If they're not capable of receiving it, you have an exclusion. But if you've completed an application within 60 days of the reporting period and you're still waiting to an invitation to test and validate, you're good to go. Once you receive that invitation, you need to respond within 30 days to begin the testing and validation, and then you continue to test and validate until you get it right. And once you get it right, you then continue active submission of data. So that's what active engagement is.
Paul, there's another question on here asking about the specialized registries. Are there any criteria for becoming a specialized registry?
I can't answer that particularly about what criteria there are for becoming a specialized registry. We can ask that question and try and get an answer back to you, but I cannot answer it offhand. So I think I was talking about the reportable labs for hospitals. Again, we come back to this active engagement of submitting reportable labs to a public health agency, and we've already talked about what active engagement is. You've requested the ability to do it within 60 days. You're waiting a reply. You get a reply to actively test. You're in the process of active testing, or you're in the process of ongoing submission. And you have the same exclusions. You don't order reportable labs, or there's no public health agency with the capacity to receive them. Now, these are the elements that have been deleted from stage 1. Demographics, vital signs, medication use, allergies, smoking, advanced directives, all the measures on the left-hand side, you're not going to have to report individually. All of those will show up in a particular element on the right-hand side, but not all of them will. So, for example, advanced directives is not going to be measured at all. in stage 1 or any of those stages. But most all of those will show up in electronic access to health information or electronic access and the electronic summary of care document. Patient lists and patient reminders are also no longer going to be measured for stage 1. So the changes to stage 2 in 2015 and 2017, we see here. This basically summarizes everything that I said around stage 1 in a single slide. So you can see, if we go down a little ways and see e-prescribing with formulary parenthesis EH, where you see the M in that column next to it, that was the menu item for hospitals to e-prescribe on discharging from the hospital or the emergency room. They may claim an exclusion, we see in 2015 for stage 2 because it was a menu item, and they may continue to claim an exclusion in 2016 because it was a menu item. However, in 2017, we can see it's in yellow, it becomes a core item. So the green means it's nicer, the yellow means it's a new one, and you can see all these going across, basically summarizes what I said in the previous slides. And I believe it's out of order. I'm not going to go back to it, but I have that same, maybe I can go back to it, hang on a second. Oh no, I can't jump very easily. Let me see, maybe I can. No, I can't jump very easily. There's a similar slide earlier on that we'll put in order that talks about these very same specific changes for stage 1. So these are the ones that are deleted from stage 2 from 2015 to 2017. Again, some of them are showing up. See, the first 3, that case reporting that they had considered in the proposed rule has been dropped. Public health, clinical data registry, and cancer registries have all been combined into the specialized registry for stages 2 and beyond. And again, we see where all the other elements begin to show up that they're not actually individual measures, or they're not measured at all. For example, electronic medication administration record for hospitals is no longer being measured. Provider notes aren't specifically being measured either. Imaging results aren't specifically being measured anymore. So again, there's some flexibility now built within both stages 1 and stages 2 to make it easier for you to be able to attest to meaningful use. And actually, the idea is to really get on to where you begin to use your electronic health record effectively and actually use it to improve care and not just spend a lot of time checking checkboxes and doing that other stuff, which really does not have a lot to do with improving care. So here's the exclusion element that, and it has a direct link to where you'll find this language in the Federal Register. We understand that the intent or lack thereof may be difficult for a provider to document and will not require documentation that a provider did not plan to attest to a menu objective for the provider to claim the alternate exclusion. So you're not going to have to document it, but again, what I don't know is that if you do claim every single one of those exclusions, you would not have been able to do the appropriate number of menu items had there not been this new proposed rule. So we'll have to wait and see. Again, throughout the time period of through 2017, you'll be able to use 2014 or 2015 certified EHR technology when it becomes available. So you can use any mixture, but again, when you're in 2017, if you're doing stage 3, which we didn't really talk about today, you'll have to be using 2015 certified EHR technology. There's really no change in clinical quality measure reporting for 2015 through 2017. It's the same method, domain requirements, and number as for 2014. In 2015, it's any 90 days in the calendar year, and it does not have to correlate with your reporting period, so it can be any 90 days. Again, eligible hospitals have those 3 additional months at the end of calendar year 14 that they can use for their reporting. But in 2016 and 2017, it's going to need to be a full reporting year of clinical quality measures for everybody except those in their first year of meaningful use. So your reporting options. You have a number of options that you can apply that when you're reporting your quality measures. So for example, Option 1 is you attest to the clinical quality measures through your EHR registration attestation system. That's the way that a lot of people have done it over time. But you also have the option right now of you can also report your quality measures through the PQRS portal, and by consequently doing that as an individual provider, you would then qualify for both your PQRS reporting and you would also qualify for your meaningful use reporting. There are also a number of other options that align with some of the other quality programs, and there's a link down here that points to exactly where these are located on the CMS website. Option 3, report individual eligible professional clinical quality measures through the PQRS portal. Another option is report group CQMs through the PQRS portal, and that would do you for both. Or report group CQMs through Pioneer ACO participation or Comprehensive Primary Care Initiative participation. So both of those are available for eligible professionals. For hospitals, they also have a couple of options. They can attest basically through the standard methodology, or they can also report through the hospital inpatient quality reporting system, and that would count as well. Either of those would count for the meaningful use attestation or the clinical quality measures for hospitals. So that pretty much summarizes the elements here. So what I'd like to do is ask my folks here to point out some of the questions that have come in that they would like me to answer.
And I would just like to let everyone know if we are unable to get through the questions, or if there are questions that we might not be able to answer right now. We will, in the next few days, go list out all of the questions that we have received and then provide answers to them. And again, we will send those out to everyone who has registered for this webinar.
Quick answer, what is e-access? That's patients' electronic access to their health information. I just used the shorthand on that one. I saw that one.
Perfect. Okay, so.
And why don't you open the lines too while we're at it? So if there are any verbal questions while we're looking through the chat, I can answer verbal questions and chat questions.
So here's the first question. In a practice with both nephrologists and endocrinologists, would a nephrology registry cover both specialists?
Yes, that question came in last week. In a practice that has both nephrologists and endocrinologists, it would count for both of them if they're both treating and addressing those same patients and those particular diseases, because, again, you're basically submitting to that same registry. Now, the details exactly on how you're planning on do it may make that not count, but I'm assuming the nephrologist is, let's say it's the diabetes, the nephrologist is submitting to the registry, and the endocrinologist is submitting to the same registry for the same patient, then it would count for both of them.
Is there someone on the line that has a question?
If you have a question, please press the number 7 or the letter Q on your telephone keypad. Our first question comes from Chi Ho. Chi, please go ahead.
You say we can test for any 90 days. So if I want to test, say, choosing July 1st of this year to September the 30th of this year, is this period okay?
Yes, that is correct. You can, and it doesn't have to correspond with a quarter either. It is really any 90 days. And again, to make that clear for hospitals, it could even be December 1 through February 29th. December 1 of 2014 through February, say, 28th actually of 2015. That would span 2 formal years, or 2 formal calendar years, but it would work for them. So any 90 days within the measurement period. So hospitals get for 2015 get a 15-month measurement period, and eligible professionals get a 12-month measurement period. And after 2015, it's going to be, the period for which you can select is a calendar year.
So now that before the new rule came out, I registered for the whole year, full year to test. So if I choose a period from July to end of September, and you said it's okay. So when we report for like patients security, send question back to me. So I think it's called this core measure or menu measure 17. So I have many then one patient who answered back to me. So the requirements 25%, I have almost 31%. So I just report 31%, right? For the particular core measure.
For the patient replying back to you again, for this particular year, is at least one patient. So I imagine the way they may set up the attestation system for that particular question is going to be a yes or no. When they get to the percentages, they may set up things that you'd be entering your percentages.
Okay, so I just follow whatever they ask, right?
Correct.
Thank you very much.
Our next.
Is there a question that one of the participants had? Can a first-time attester who is eligible to attest with Medicaid attest with CMS to avoid the penalty, in quotes, because Medicaid will not open by 2/29? If so, would they then reattest again later to claim a Medicaid EHR incentive payment?
Each particular state has their own calendar of when they set their deadlines for attestations. So, for example, our state of Minnesota, they've actually extended the deadline. I don't know the exact number right now, but it's well beyond the February 29th date. I think it's sometime in March. So I would check with your own state Medicaid to find out what the deadline date that they're setting up for attestation. They need to get permission from CMS in order to do it, and CMS is very good about giving permissions to the states to do something like that. That is one place that the states are allowed flexibility. There's a question on, there's a verbal question?
We do have a question from Amy Fogeltons. Amy, please go ahead.
Yes, we are a small GI specialty clinic, and I'm wondering where would I find the items that qualify as a syndromatic surveillance reporting or a specialized registry?
Boy, you ask a really good question, and you know, that's something that I have asked that we try and create a registry of registries so that we know what we have to choose from, because it is going to be a challenge for us to be able to answer that question. So I wish I had an answer for that, but I do not. You know, I would talk to your specialty society. Your specialty society may wish to collect some of that information for your particular providers in their specialty. They may also be able to collect some of that information from states that's relevant to their particular scope of practice. So I do not have an answer for that, but I think that's definitely an issue that's going to need to be addressed.
Okay, thank you.
You're welcome.
So it's past 12:30, so I think we're going to have to end this webinar now. As I said, we will have all of the questions that we've received in chat, and we will put them together and get some answers for them and get those out to all of the registrants.
And you're also sponsoring a chat session at some point in the near future about this too, or you're not, where it's just, as a poster presentation, it'll just be a back and forth chat where people can ask questions?
Yeah, the region, the LS Quinn region will be putting out, watch for an advertisement about that we will be putting out a live chat session regarding meaningful use. And again, that is just merely a question and answer session as well.
So some of these that you've not had a chance to get asked today, or we will not be replying to today, or you think about later, that would be a great place for you to participate and get some of your questions answered.
So thank you, everyone.
Thank you. This does conclude today's teleconference. We thank you for your participation. You may disconnect your line at this time.